Okay, so what we're going to talk about today is entrusting learners to care for patients. So I have no conflicts of interest. And as Rena mentioned, I am a faculty member for an international course on EPAs, and some of the slides I used in this talk are adapted from that course. So what I want to do today is talk about the concept of entrustment in the clinical supervision of learners, and then talk about the 5 learner features of trustworthiness and how we might apply that to learner assessment. Think about how entrustment can be used as a framework for competency-based education, and then talk about the implications of this idea of trustworthiness for clinical supervisors and our educational programs. All right. So why talk about entrusting learners in the first place, right? And I think, if we think about what we do in the health professions, we make entrustment decisions every day when we work with our learners, right? We decide how much we're going to let them do with our patients and with how much supervision and other people around. So if we back up a little bit and really think about the workplace and how do we teach and learn in the workplace, studies, Lee Schulman, who's with the Carnegie Foundation, actually looked at law and medicine and even the ministry. And what he found was, consistent with how professionals have learned their professions over the years, it's really through an apprenticeship model. And it describes that there are really 3 threads in the apprenticeship. There's the apprenticeship of the mind, how we think, the apprenticeship of the hand, the procedural skills, how we do what we do, and then the apprenticeship of the heart, our ethics, morals, professionalism, what it is that the profession stands for. And our learners learn that through observation, through the coaching that we provide, and through actual practice, right? So as in this photo, the boy practices making a shoe. And through all of this, then our learners are really socialized into the practice of medicine. So in the late 1980s and early 1990s, there was an anthropologist and an education specialist who really then studied apprenticeships in depth. And what they did was they came up with a learning theory called situated learning, with this idea that we learn best when we learn something in the context in which we will be applying it. So again, learning in the workplace. And what they did was they started to describe learning not as acquisition of knowledge, but learning as participation. We learn by participating in the workplace and contributing to the workplace. So what they said is that learners join in medicine clinical communities of practice, right? So I have a student, but they actually join an entire team in caring for patients. And what we do is in the beginning, as we have them join our community, is we have them participate, but it's what Levin Wenger did is they called it legitimate peripheral participation. So it's a legitimate participation in that they're doing work that really does contribute to patient care, but it's more on the periphery, right? Where there's sort of lower risk activities where we can manage the risks if something were to not go right. And over time, what happens is someone, as our learners grow and develop, we give them more and more responsibilities. And we do this by balancing supervision and autonomy, right? So we start to back off on supervision. We start to give our learners more autonomy in what they do. So this idea was then applied to medicine really in the 2000s. And all around this time, then people became very interested in this idea of supervision and what actually is happening in the clinical workplace. So Tara Kennedy from Canada did a study, and this was really seen as the seminal study, the first to really look at supervision in the clinical workplace. And what she did was she talked about how there's actually 4 different types of supervision. What she calls routine oversight, when we know that they're planned activities and we sort of review each patient with the learners. There's responsive oversight, where we provide oversight in response to a learner issue or a patient issue. There's backstage oversight. So, we're sort of double checking the labs in the back, but the learner doesn't realize that we're doing it. And then there are times where we have to take over and do direct patient care. So as I said, this was really the beginning of the conversation in the literature around, so how does supervision work in the clinical workplace? But in addition to the different types of supervision, you can also think about different degrees of supervision, right? Again, that balance of supervision and autonomy. So you might imagine that as someone is learning to do something, initially we're in the room with them, right? We're sort of providing direct supervision. At some point then, we trust the learners enough to say, you go ahead and go in and you do that exam, and then you come out and tell me what you found, right? Sorry for all these pediatric images. I'm a pediatrician. And then we might say, well, I trust the fellow enough, for instance, to be running the neonatal ICU. And maybe I don't even need to be in the unit, but I'm in the hospital somewhere if they need me. And at some point, we might even say, I'm comfortable leaving the hospital, right? I can be, down at the convention center for a conference or somewhere, and then the fellow can call me or the resident can call me if they need me. And at some point we say, okay, you're ready to fly, and we kick you out of the nest, right? So that our learners go on and can be doing unsupervised practice. So then this is how we can think about how supervision is related to entrustment, right? So it's a balance of what can I trust you to do with how much supervision. This is actually a photograph of me when I was a very, very junior attending. This was in the pediatric urgent care clinic, and this was a medical student. And basically, I wouldn't let the students put an IV in a child unless they could prove they could put an IV in me. So they would all practice and put an IV in me. And if they were successful in putting an IV in me with coaching, then I would let them try in a patient, right? Okay. So as we then start to think about this balance of supervision and autonomy, Tara Kennedy continued her work and started to look at, well, then how do supervisors decide, right? How do we as faculty or supervising clinicians decide how much supervision we're going to provide? And she did a qualitative study where she actually followed around medicine and emergency medicine team. She did like 6 observations, watching them for 3 hours. She also created these video vignettes where there were supervision challenges, for instance, a resident ordering the wrong labs, and then interviewed faculty about how they felt about these things. And what she decided was that from her findings is that people seem to be making decisions based on 4 dimensions of what she calls trustworthiness, right? So this is how much knowledge and skill the learner has. The second dimension is discernment, sort of the sense of, are they aware of their limits, right? So you're more comfortable with someone who knows their limits than someone who has no idea of what their limits are. The third dimension is conscientiousness, right? How dependable or thorough someone is. And the last was truthfulness, the sense of the absence of deception, right? Will someone tell you the truth if they didn't get around to doing something, or will they lie? Now, since her work, there's been multiple studies looking to confirm this and looking to sort of what define all of the different learner qualities in the decisions that we make to trust. Studies have been done looking at attendings and residents, because residents make decisions to trust students, for instance. They've been done in anesthesia, OB-GYN, pediatrics, surgery, and even in veterinary medicine. And what we find is that everyone defines their categories differently. So depending on the study, you could have 3 different quality categories or up to 24. People used a lot of different terminologies, a lot of overlapping concepts. And then sometimes they use the term or what they say is the same concept to actually refer to completely different phenomena. And so Ola Tenkati and I then actually went through the key papers and then essentially did a qualitative analysis. What is it that people were finding? And we boiled it down to 5 factors. So one is capability. So this is the knowledge and skills, the experience the learner has, and their situational awareness, right? The second is reliability. So how conscientious someone is, but also how predictable, right? Is this a student or a resident with really, really good days and really, really bad days? And you never know what kind of day they're having, or are they pretty consistent in their performance? Are they accountable, and are they responsible, right? Integrity is that, Are they truthful? Are they benevolent, meaning that they're doing what's best for the patient? And are they being patient-centered in how they care for the patient? Humility is that discernment category, right? Do they recognize their limits? But in addition to that, are they willing to ask for help, receive it, and are they receptive to feedback? And this is not just feedback, for us in medicine from others in medicine, but receptive to feedback, for instance, from the nursing staff, from respiratory therapy, from the physical therapist, right? And then agency is, are they proactive in their work? Will they go check something or check in with the patient without being told they need to do so? Are they proactive with their team in thinking about safety and also their own personal development and growth? Okay. So if you were to take the first letter of all of these, you could create an acronym. And so basically say that these are the 5 factors that will allow you to make a rich entrustment decision. Okay, so agency, reliability, integrity, capability, and humility. All right. Oops, sorry. So what does that actually look like? And I always like to give this example of when I was working in the urgent care clinic as an attending. So one time I worked with, 2 interns. I've changed the interns' names. So one intern, David, very much expected knowledge and skills for an intern, but David was really good at identifying his own gaps and asking very good questions. And he would even say things to me such as, I'm really unsure of this finding on the physical exam. Could you repeat it? And then we can talk about it. Amy, the chief residence, called me and said, you're going to love working with Amy. This is the most advanced intern we've ever had in our program. Very impressive knowledge and skills. But what I found working with Amy over time was that she never asked for help. Never, even when she should have. And there are times where I found that she didn't really report key findings. And then when we called her on it, it was a little squishy in terms of why. And I wasn't always very sure that she was being honest, because she had so much writing on being the most knowledgeable and skilled intern in the room. And what I found over time was I gave David a longer and longer leash, right? In terms of I entrusted him to care for patients because I knew he would come get me, right? If he needed help, I knew that he would point out where the gaps were. Whereas Amy, I gave her a shorter and shorter leash, and I found that I really couldn't trust her to do very much. And I double checked everything, right? So this is sort of like the difference between thinking about just knowledge and skill and thinking about entrustment and supervision and all the other things that come into play when we have to make those decisions. So then again, around the time that all of this is happening is Ola Tenkati, who is an educationalist in the Netherlands, was trying to think about how can we improve workplace-based assessment. He had a friend who is an attending obstetrician gynecologist. So he said, can I just follow you around one day? Let me just follow you around, and I want to see how you make decisions to help me think about how we can improve things in the workplace. And he was noticing that this attending was making different decisions about what to entrust different learners to do. Right. And so it's basically he was watching entrustment supervision decisions happening like in the moment and in action. And then he came up with an idea and he said, what if we actually focused education on patient care activities and we thought about readiness for practice as when someone can be fully entrusted to do these activities? So he came up with this idea of entrustable professional activities, and they're units of professional practice that can be entrusted to a sufficiently competent learner or professional. So in other words, if we were going to think about obstetrics and gynecology, what are all of the professional activities that an OB-GYN should be able to do, right? And so it's the essential concrete clinical activities that a profession would be responsible for. These are activities that actually allow us to make deliberate decisions about entrustment. Who can I entrust to do this and with how much supervision? And in essence, then, once you've mastered all of the EPAs for that profession, then you've achieved full competence. And I'll provide a few more examples and explanations. So, and I know that I think earlier in this series, you guys have talked about competency-based education. right? So, the model for competency-based education is we want to determine what the health needs and the system needs are. With that, then we define the outcomes that we want from our education, and those outcomes will drive the curriculum and drive our assessments, because we want to build a curriculum that will help us achieve those outcomes, and our assessment will help us make sure that we did in fact achieve those outcomes. And so the idea around EPAs is to say, well, what if we were to define our outcomes based on these activities that someone should be able to do? We would then build a curriculum that basically gets people to this space of being able to do these things unsupervised, right? So we would build a curriculum that allow progressive autonomy and less supervision. And the assessment ensures that the graduates can be entrusted for the EPA. So the assessment is really around how much supervision does this person still need? And we don't graduate them unless we're sure that they can now do this safely unsupervised. Okay. And so here are some example EPAs from graduate medical education. So they've been defined as outcomes. So one for internal medicine is manage care of patients with chronic disease, manage high-risk childbirth from OB-GYN, manage psychiatric emergencies from psychiatry, manage a non-OR patient with chronic pain from anesthesia, or care for a well newborn from pediatrics. Okay. And then here's just a sample of the 13 that the AAMC came up with for graduating medical students. So they need to be able to gather a history and perform a physical exam, to prioritize a differential diagnosis, right? To recommend and interpret common tests, to enter and discuss orders and prescriptions, to document in an EHR, to provide oral presentation, and to give and receive patient handovers. So this is just an example of how we think about activities as outcomes that we're interested in. So the things to know about the key elements of an EPA approach to competency-based education is that it's a much more holistic approach to the competencies, right? Because I'm talking about care for a well newborn, right? It's not really broken up into patient care competencies, communications competencies, or practice-based learning and improvement, right? They're sort of all intertwined. It links this idea of entrustment to supervision and assessment. And what this does, it really highlights the consequences of assessment. So what do I mean by that? So in traditional workplace-based assessments that we do, right, the psychology is, our learners, and primarily students, right, will say, ooh, please give me the highest ratings. They want the highest grade if possible. And what happens often with our faculty is, she's really nice, she's worked hard, and it wouldn't hurt her and will probably motivate her if I give her honors or a high grade, right? Because the way we think about this, the grade only impacts the student. It doesn't impact anyone else. So what's the harm? Okay. The psychology of a entrustment-based workplace assessment, right? Student or resident still comes, give me the highest rating. But now she's nice and she works hard, but it may hurt my patients if I say that she's ready for unsupervised practice, right? Because the rating is tied to how much supervision someone still needs. So I sort of reference these levels of supervision. So I'm going to show you what the supervision entrustment supervision scale looks like. This is the original one that was proposed in the EPA framework, and this was meant for graduate medical education. And you'll notice that you progress from not being allowed to practice in EPA through different types of supervision to the point where you can practice it unsupervised, and then you're allowed to supervise others in that. And generally, the idea is that moving from 3 to 4 is then what allows you to graduate from your GME program. Okay. So this is just to show you that we've expanded the scale with more intermediate steps, which then can be applied to undergraduate medical education, though it's been applied by others, even in graduate medical education. Also to show you that this idea of supervision, even outside of EPAs, was starting to be attractive to other people. This is the switch scale that the surgeons came up with. This is the supervision levels in the OR. So did I have to show and tell the learner everything? Did I only have to provide what they call smart or active help, right? Did I only have to provide dumb and passive help, right? I'm just standing there and I just wait until the learner asks for help, or I'm just there to really monitor things. I didn't really have to give any help. In Ottawa, the orthopedic surgeons came up with a similar scale for the OR, and then they adapted it to be able to be used in the clinic. And again, you'll see it's different levels of supervision. And then this is what's called a Weller scale, and this was developed in Australia and New Zealand by the anesthesiologist. And their levels of supervision in anesthesia has more to do with how long and how far away the anesthesia attending can be out of the OR. Okay, so you'll see brief coffee break, lunch break, so forth. And what's very interesting, the difference between brief coffee break and lunch break is apparently in Australia and New Zealand, there's a little tea room that's attached to their ORs. And so you can just step right next door to have a coffee break versus when you're having a lunch break, you might actually have to leave the floor to go get your lunch. Okay. So now the reason why there's a lot of interest in the entrustment supervision scale, as I mentioned, it sort of changes the psychology of things. So in Australia, they compared the use of an entrustment supervision scale against a regular proficiency scale. And that's the, did something poorly to did something very well. And they did this using the mini CPX. They use a 9-point scale for both. And they basically used it to study anesthesia residents in 3 different hospitals. And this was done by different attendings. And they collected over 300 ratings. And what they found was that when you use a traditional scale, the variance that you see that you can say it's based on differences in trainees is only 9%. The variance, most of the time, 40% of the variance is actually based on the rater. It's a problem having poor inter-rater reliability, and that you would need to do more than 50, right, across different raters in order to get to 0.7 reliability. And we kind of know this. This is everyone's stress about workplace-based assessments, right? Now, what happened when they used the supervision scale is they were able to double the variance that was due to the trainee. They cut the variance and the raters almost by half, and they could reach 0.7 reliability with only 6 assessments. And this idea being that probably it's easier to get supervising clinicians to a shared mental model of how much supervision someone provides versus what constitutes good and what constitutes excellent, and what constitutes poor. Okay. The other thing that I want to bring up that's interesting about entrustment and supervision is that it tends to push us more into a prospective space rather than retrospective space. So a retrospective thing is to sort of say, by the end of training, if we do an assessment, the question is, does the learner demonstrate the mastery of the content that's been taught, right? Versus being forward-looking is asking the question, is this learner ready to assume the expected future responsibilities that we want them to take on? And I'll give you sort of an example that might help hit home. So this is the idea of past performance versus future risk. So this is just a model like I drew up on Excel. So you have learner 1 and learner 2. Let's say that 0 on the y-axis is the threshold for safe patient care, right? And I will tell you that the average score for learner 1, learner 2 are exactly the same. The average score is 2, okay? So, but this is exactly what we ask all the time, right? When we look at performance and we sit down to decide whether someone passes a rotation, whether someone can graduate from residency, we ask, what is the average competence of this learner, right? And the answer is the same for learner 1 and learner 2. But now, if the question is, how big is the risk of this learner performing seriously below standard in a future case? The answer is different, right? If you had to pick one of these to do the appendectomy on your loved one, you're going to go with learner 2, right? Because even as they have variable performance, it is always above the threshold for safe patient care versus learner 1, where they sometimes perform below that threshold. And that, again, is the difference between looking towards the past versus thinking about what the future risk is. Okay. So there are 2 different types of summative entrustment decisions, and I just want to bring that up. There's decisions that we make as clinicians on the front lines, where we're asking our questions like, should I trust this learner to perform a physical exam on this pediatric patient now? These are what we call ad hoc decisions, versus much more of a competency committee decision, where it's a, shall I trust or certify this learner to perform physical exams on all pediatric patients from now on. Okay. And what I'm going to talk about today is more the ad hoc decisions, because that applies more to all of us, and it applies to all of us in what we do in the clinical setting, whether or not we are operating in an EPA framework, whether or not we're doing competency-based education. It's just a matter of apprenticeships, is we're always making these entrustment decisions. So when we make these decisions in the moment about, should I trust this learner to care for this person now, there's actually multiple factors that come into play, right? So it's not just about the learner, but who we are as supervisors come into play, what the task is, our relationship with the learner, and then the context makes a difference. The learners we talked about the 5 learner factors, but we also think about their learning needs. As supervisors, so how much clinical experience we have, whether we're more likely to trust someone or less likely to trust someone comes into play. How difficult the task is or how involved it is, right? Like our relationship with the learner, do we feel like we're very like-minded? Maybe I've known them for much longer. I'm more likely to trust them than someone I've not really met before. And then the context, right? So how many other people are around? Do we just need hands on deck the time of day? We already do. We allow people to do all sorts of things on call overnight that we don't have them do during the daytime, right? So all of this comes into play. So then the question is, with all of this going on, is how do learners understand what's happening, right? So there was a study that was done looking at students in a traditional clerkship, and they chose students because students are at the bottom of the totem pole in terms of entrustment decisions. And they wanted to ask them, what is your experience of supervision and the impact on learning and patient care? And this was done at UCSF. And what they found is that the clerkship students recognized that there were various influences on decisions, but they didn't understand what those influences were and how they might contribute in terms of learner factors. And what comes up is just a tremendous amount of frustration, a sense of a lack of control over decisions that are happening to them, right? So they talked about times when they get lucky and it's an appropriate level of supervision or trust. They talked about times where they were under-trusted or over-trusted, which impacted their learning and also, created problems in terms of safe patient care. But what's interesting is the reason why the learners were so incredibly frustrated is they were also really uncomfortable addressing it, right? So they didn't feel comfortable going up to someone to say, I need more supervision, or that I am capable of more, okay? And this is in contrast to a study we did looking at students who were part of a pilot curriculum using EPAs. And because we were using EPAs, all of the students got training on how entrustment decisions are made. And it was explained to them that there are contextual factors, supervisor factors, but there are also student factors. And so when focus groups were done with these students, what we found is that it really came through in how they talked about it. The students did recognize that there were influences on decisions, and they just let go of the elements that they had no control over. Right? Like it is just the way it is, that some supervisors will be more this way or that way, and that there's context. It has to do with the task and what's going on. But they also recognize which elements they had control over. And what's interesting is they were very deliberate in exercising their influence over decisions. So they talked about how they would demonstrate agency and reliability, integrity, capability, humility. They talked about how, like, if I admit I don't know something, if I'm honest, my supervisor will trust me more and eventually I'll get to do more. And the other thing is that they also showed agency in really negotiating the over and under trust. So there are times where students would, show up and they say, you're a third year student. I don't expect you to know anything. Just come in and observe. And the students would say, actually, I'm capable of more. Why don't you come in and let me lead the visit, but you watch me, but you can jump in whenever you need to. Okay. And also when faculty said, oh, you know how to do this, you don't need me, the students would also say, no, I've only done this once successfully. I still need you to supervise me because I'm only doing this once, right? So they were much more comfortable in negotiating it because they knew all of the factors that went into these decisions. So I think our lessons learned from that is that, again, whether or not you use EPA, you're thinking about competency-based assessments, we're making entrustment decisions all the time. And ideally, we make them based on goals for patient safety and preparing learners for independent practice, right? And what we want is we want to be explicit with the students about and the learners about how we make those decisions. And then we want to help develop, assess, and hold them accountable for all these things, right? Learner agency, reliability, integrity, and humility, in addition to capability. And part of that is we can focus all the feedback on helping them develop autonomy. So for instance, what we found in a lot of spaces where we started using more of an entrustment framework, it's students and residents would ask for feedback, not how did I do, but what should I do differently to have more independence next time, right? What can I do to give you so that you're more comfortable giving me more responsibility? And it allows the faculty to say, I would feel more comfortable giving you more responsibility next time if I felt like you would admit when you didn't know something. If I felt like you would come get me if you were in over your head, if you could recognize when you were in over your head, right? It allows you to give feedback on all these other things in addition to knowledge, skills, and experience. Okay, so all of this has implications for the learning environment. Right, so we talked about these learner factors and we think about integrity and humility, what usually happens, right? So when a learner doesn't meet our expectations for integrity or humility, we usually blame the learner. We treat trust as unidirectional, right? So there's something wrong with you and therefore I can't trust you and I can't entrust you with care because you have a character flaw and you're just not an honest person. I always like this quote from the Macy Foundation, where they said that there are attributes that we desire in our learners. And the learning environment should bring forward those attributes. And we are the stewards of that learning environment. So then I always ask, are we trustworthy? Right? So do we create an environment where it's safe for students to be honest? Where it's safe for students to admit that they're beyond their limits and they need help, right? Or that they overslept and didn't look for the labs. And as long as we are not trustworthy, then we can't expect the students to demonstrate vulnerability and showing their humility and integrity. So the questions for us as faculty, right? Are we the type of faculty that say, it isn't my fault if they're too stupid to be in medical school? Are we the type of faculty that say, if you guys ever don't understand anything, that's not your fault, but my fault, and please let me know because it means I'm not saying something right, right? And these are quotes from actual faculty I've worked with. And as a program or a department, what is our culture? And I put this here because in one of the pediatric departments that I worked in, we needed to consult orthopedics, but that orthopedics department had a culture of, you are weak if you don't block access to the senior resident and the attending. And you're a strong intern if you block access. And we could never, the pediatric residents could never get a hold of a senior resident or a faculty member because the interns had this culture of blocking, but the interns knew nothing about pediatrics. And so it created a huge problem for patient safety to the point where the pediatric orthopedic attending gave out his personal cell phone number to every single pediatric resident and said, just bypass all the residents and call me directly. But this has implications for learning, right? So none of the orthopedic residents now are engaged in learning about pediatric orthopedics. And then as an institution, right, do our learners trust that if they stumble and are struggling, that we're going to help them across that finish line? Or do we say, too bad, you don't meet our criteria, we're going to drop kick you out of this program, right? And that is a lot of the fear and a lot of the learners that, any mistake is going to cost them their career in medicine, and that can drive a lot of these behaviors that we don't want to see. The very final thing I'm going to leave you with is this idea that the environment is not the same for all our learners. So I've pulled your attention to the environment, but I also want you to be careful and think that, oh no, our environment's fine. We have this subset of learners says that everything is wonderful, right? So organizational structures, practices, and patterns of interaction really position groups of learners differently, and it creates very different experiences for them. And then the groups respond differently due to the differences in their situations. So I think when we think about trustworthiness and safety, we have to make sure that it's there for all our learners and not just subsets of them. Okay. So we talked about how supervising clinicians practice entrustment daily, right, in balancing supervision and autonomy for safe patient care. We talked about the learner factors, agency, reliability, integrity, capability, and humility. Talked about how entrustment can be used as an assessment approach and a framework for competency-based education, and the fact that learners will demonstrate trustworthy behaviors when we are trustworthy. Okay. I'm happy to